Morning everyone. The topic I am going to cover is can we better perfect biometry. In earlier times, cataract was removed first and spectacle prescription given last. But today we calculate the power of IOL first and the cataract surgery is done afterwards. So IOL calculation plays a very important role to determine refractive outcome after the surgery. And since 75, IOL power has been basically calculated using only two parameters, keratometry and axial length. But today, we can customize the power of IOL to achieve near plano result even in highly refractive eyes. There are a group of patients who value their emetropia so much when you break news to them that they require spectacles after cataract surgery, they are extremely disappointed. And what are the major sources of prediction error for IOL power calculation? ELP prediction 35.5%, followed by axial length measurement and keratometry measurement. Few subjects in the field of ophthalmology are as complex as IOL power formulas because it depends on with the help of mathematicians, and we ophthalmologists are not very fond of mathematics. There were hurdles in accurate estimation of effective lens position because older formulas worked on some assumptions. That is, the shorter eyes and flatter K eyes were supposed to have shallow AC and shorter effective lens position in contrast to longer eyes and steeper K eyes. But Holiday taught us that there are 9 types of eyes. Eyes with normal anterior segment, 80% may have short axial length and 90% may have longer axial length. And similarly, in patient with normal axial length, 2% may have the varied anterior chamber depth on either side of the spectrum. So relationship between anterior segment size and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formula is bound to fall in shorter and longer eyes. Is it so bad to just keeping using the old formulas? Yes, because with that only 1% of the surgeons achieve more than 92% accuracy within plus minus 0.5 diopters. This was Rayner medal lecture given by Warren Hill. They said if you start using newer formula, that this percentage improves to 91% of eyes within 0.5 diopter of the target refraction is achievable. I'll straight away jump to the newer formulas like Hoffer H5, Ladas, Olsen, Barrett 2K, Barrett Universal and Hill RBF. Prediction theory says more the number of variables, more accurately you can predict the outcome. So we have jumped from 2 variables to more variables. We have 5 variables in Barrett Universal and 7 variables in Holiday 2 formula. And we also have the use of artificial intelligence and ray tracing in Oculus and Phaco optics. And there were some other assumptions also that we always assume that there is fixed ratio of anterior and posterior corneal curvature. Cornea was treated as a thin lens with uniform refractive index of 1.3375 and actually it is 1.37. And so this gave us good result in average eyes but not in atypical eyes. So there were some constants used to emetropize and achieve emetropic results, and this was A constant in SRKT, A0, A1, A2 in Haigis, personalized anterior chamber depth in Hoffer Q and Holiday 2, and Holiday 1 had surgeon factor and Barrett has lens factor. But mind you, what are these lens constants? These were typically developed during later stages of regulatory process when plano convex lenses were used and contact ultrasound biometry was used. But now we have shifted away from contact ultrasound biometry and the lenses are no longer plano convex. So optimization of lens constant is required. Either you can do yourself depending on your results, or you can use various sites like software, Biometer, IOL Master or Haigis ULIP website. Surgeon who does not personalize his A constants, they repeatedly have errors which are more than 0.5 diopters in almost all their results. So if you start optimizing your A constant, you will see on the left side, your results within 0.5 diopter improve from 18% to 70%, and within 1 diopter they improve from 50% to almost 95%. Let's talk about the newer formulas like Barrett Universal 2. Here we use lens factor, which is influenced by not 1 but 4 factors like keratometry, axial length, anterior chamber depth, lens thickness and white to white measurements. Hill RBF depends not only on artificial intelligence but also on pattern recognition. Olsen formula uses ray tracing and thick lens concentration to predict effective lens position, and Ladas is very intelligent. It combines the best performing portions of multiple 3rd and 4th generation IOL calculation formulas. Kane is a newer formula which, besides the factors taken in the Barrett Universal 2, also takes into account central corneal curvature and gender of the patient to make its predictions. EVO 2.0 formula is also a new formula which is giving us very good results now. Intraoperative aberrometry, although it came with a bang, but it is valuable only as a confirmatory or complementary test, and it is not going to make lens calculations obsolete in the near futures. Ray tracing gives us true geometrical effective lens position and is incorporated in Oculix and Allsense, but there are limitations of ray tracing. That is, it is not outperforming the standard third generation formula, so there is no reason to switch to the ray tracing formula. Hill RBF formula not only gives us the accuracy level, it also gives us this thing whether your result is inbound or out of bound, depending on whether the database has the enough data paralleling your specific case. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, and although they use, I'll just take a minute, sir. Although they use completely different theories, but they give results which are within 0.25 diopter of each other. So what should I do? Should I use multiple formulas? Koch says yes, use multiple formulas. But Holliday and Barrett says use specific formulas for specific condition and don't average your results. So these are the newer instruments. So what is the best way to deal with short eyes? Traditionally, we were using Hoffer Q, but now the literature says use Barrett and Hill RBF. So conventional wisdom has been overtaken by smart wisdom. And this was the meta-analysis done in shorter eyes, and they found that Kane, Barrett, and EVO are giving us better results. These are the literature from 2021 and 22. And in longer eyes, what should be done is, again, what they have shown is EVO 2.0, Kane, Barrett, and Hill RBF are outperforming. And these newer formulas you don't have to buy, they are available on the sites. And this is the meta-analysis which has been done in longer eyes, shorter eyes, and you find that Kane, EVO, VRF, Barrett, Hill RBF, and Pearl DGS are the formulas. So we no longer talk about the Holliday, Hoffer Qs, and Hagees, and the newer formulas have clearly taken. So these are the steps you can take to maximize the likelihood, optimize your lens constants, validate your measurements. Yeah. So this is how take measurements yourself. Don't remove yourself from the process and become totally dependent on your optometrist. Spend extra time counseling patients after refractive surgery. So 90% within 0.5 diopter is achievable. Why we are not able to go beyond 90% is because the precision limit is 0.25 diopter for keratometry, axial length 0.1 millimeter, anterior chamber 0.2 millimeter. So we are not able to go because the least count of these, we are not able to cross them. So can we use single formula for all eyes? Yes, if you don't have access to other formulas, start using Barrett Universal 2 and Hill RBF. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. 80% was acceptable, but now 90% now is achievable. So smartness is learning not only from your own, but also from others' mistakes. Let us not only become experienced, but also smart. So to fully enjoy this validation, use validated measurements, optimize your lens constants, and adapt to newer technologies. And for that, the present level of accuracy which we have achieved, we are grateful to all these ladies and gentlemen like Holliday, Wang, Koch, Warren Hill, Thomas Olsen, and Barrett. Thank you everyone for your kind and patience.